Defensive, Compliance, and Defiance, Part 4 of the Tough Customer series for the ISTDP Informed Psychotherapist. Actual transcripts included. So what is it? What is passive compliance and defiance? Let's absorb some general and broad descriptions of the compliance-defiance dynamic offered by Dr. Davanloo and others to capture a basic flavor of what we are discussing today. And then we will delve deep into the weeds, starting with the developmental understanding to important considerations and principles, and then lastly to some brief transcripts that highlight ways to intervene with patients. Compliance is defiance wrapped into a flower. Compliance is the most malignant form of defiance. Davanloo, Personal Communication, 2013. Stubbornness, defiance. Defiance and stubbornness can be purely tactical defenses or can be part of a major resistance. They're almost universal and appear over and over again in different patients, particularly those suffering from long-standing character neuroses. Other bright minds are worth tapping for their wisdom on this topic. In ISTDP, defiance refers to an attitude of the patient in which he does not want to look at his own faults and what he does to harm himself. Instead, he experiences his suffering as an injustice and will likely tend to experience the therapist's focus on his own contributions to his suffering as further injustice. When invited to examine his feelings, the patient in defiance experiences this as an unreasonable demand and does not turn his attention inward, but outward toward the therapist and protest. From Fundamentals of Davanloo's Intensive Short-Term Dynamic Psychotherapy, Volume 1, by Lehr Lundberg and Rathhauser, soon to be published. And now from Dr. Jonathan Entis. Defiance, compliance is part of the major resistance, part of the perpetrator, and guarding the mixed feelings, as well as interwoven with resistance against emotional closeness. They, compliance and defiance, have their tentacles in most other defenses, so they really are supra-defenses. The thing about defiance being a supra-defense is that many defenses, say passivity or helplessness, can be in the service of a superordinate defiance. So if you don't address the defiance and instead only concentrate your interventions on the passivity, you can, depending on the intensity of the defiance, fail to gain any traction. Keep in mind that compliance and defiance go hand in hand. Commonly, the compliance is more conscious than the defiance. This foreshadows the writing of Peter von Korff. Let's have a look. Patients who present with unconscious defiance are genuinely unaware of an inner, rigid negativity which threatens to undermine their efforts in treatment. In spite of themselves, they're guided by a need to fight and defeat the therapist. At its core, this type of defiance involves an unconscious projection onto the therapist, as if the therapist were standing in the shoes of a parent, a significant other, or even a prior therapist with whom the patient has unresolved issues. If unaddressed, unconscious defiance and unconscious transference projections impair the therapeutic alliance and move the therapy in the direction of a transference neuroses. The therapist's aim is to deactivate these unconscious forces as soon as they are detected. The interventions to be described undermine unconscious defiance and render powerless various kinds of projections within the transference. They take on particular significance with patients who are either highly resistant, stubborn, emotionally impoverished, or self-defeating. Early deactivation of the defiance and the transference has a corrective effect and sets the stage for the therapist's work with the patient's complex transference feelings. Peter von Korff's article touches on so many important points. He's doing us all a tremendous service with his writing. Because his writing is such a helping hand to us all, let's honor the author and avail ourselves of what he has to offer by taking a look at a few more of his paragraphs. Among the behaviors to which the therapist must attend are those which indicate that the unconscious defiance is being directed into the transference. Examples of such behavior abound, and they're quite diverse. One patient may present with ambivalence and emotional detachment, remaining aloof with the unconscious design that the therapist will become either defeated or provoked. At the opposite extreme, another patient may seem determined to please the therapist with insightfulness and apparent emotionality, but the emotionality proves to lack depth, and the patient smiles secretively when the problem is addressed. In the latter case, the patient's unconscious defiance is wrapped within seemingly compliant behavior. Davanloo has often referred to unconscious defiance as a 5-star defense. Unconscious defiance may support and underlie sarcasm, weepiness, laughter, smiling, and a host of other tactical and character defenses. The impact of unconscious defiance, whatever its manifest form, is that the pathways to the unconscious are blocked. The trained therapist comes to recognize unconscious defiance not only through gestural and verbal cues, for example, hidden smiles or sarcastic tone, but also from experience with the patient's response to various targeted interventions. Pressure and challenge do not impact as they ought, and the interview may acquire a meandering and fruitless character. In spite of a superficially effortful appearance, the patient is simply not engaged, but rather verbalizes in an essentially aimless manner. In effect, the therapist is subtly dismissed. This process is linked with these patients' ambivalence over freeing themselves from their suffering. The best approach to unconscious defiance in the early stages of the trial therapy is always an indirect one. One reason is that direct challenge to unrecognized defiance runs the risk of the patient's denial. The therapist is then placed in the unwelcome position of insisting that the patient is wrong. This situation strains the relationship with the patient, intensifies the underlying unconscious defiance, and sometimes precipitates an impasse. On the other hand, the indirect management of unconscious defiance enables the therapist to effect change in the transference relationship without diverting away from the dynamic flow of the interview or running the risk of fruitless confrontation. Let's have a look at the developmental origin of these defenses. An assault on the personhood and the will, the socialization process, the reason and function of the behavior, two sides of the same coin. If we grow up in an environment where our wants, needs, and feelings are unwelcome, and the more our feelings and our will are visible and expressed, the more we're penalized, then we're experiencing an assault on our being, our autonomy. For the child to repress her feelings in a situation like this is adaptive, as it helps her maintain the relationships she needs to maintain for survival. The repression of the emotions later become maladaptive. And that's what Davanloo was speaking to: defensive compliance and defiance in the service of self punishment, repression, and emotional and interpersonal distancing, resistance against emotional closeness. More on that later. Let's resume with a closer look at the difference between defensive and non defensive compliance and defiance. Complying with expectations and following rules is part of being civilized in the natural socialization process. But there is a world of difference between the parent who insists on the child meeting certain behavioral expectations, validates feelings in the process, and enforces consequences firmly but lovingly, and the parent who achieves behavior modification through bullying and punishments, or simply isn't present. Much has already been said about the differences between authoritarian, permissive, and authoritative parenting. But for our purposes, the important point to understand is that we can achieve socialization and behavior modification in a way that fosters healthy growth, a sense of agency and self worth, or we can relate to our children in ways that undermine the child's sense of themselves, their personhood, and their will. Saying to a protesting child, "It's time for bed, and we're now turning off the TV and getting ready for bed, but you're allowed to hate every minute of it, and if you want, when you have finished brushing your teeth, we can talk about how badly you probably want me to get hit by a train," is a world apart from saying to the same child, "Quit crying, or I will give you something to cry about." The first approach validates feelings while still being firm on structure and behavioral expectations. And the second approach demeans, devalues, and cheats the child out of the safety and respect they deserve and need to properly thrive. For people who experienced more of the second approach and less of the validating approach, there is a wounding in their will in the sense of being an autonomous agent. There is a difference, then, between complying with parental and societal expectations, because it's in our best interest to do so, and reactive, compulsive compliance that blindly goes along with others regardless of what is in our best interests. And the same with defiance. There is a difference between age-appropriate defiance and rebellion as a way to facilitate the individuation process, and blind, reactive defiance, where we by default do the opposite of what we think is expected of us, regardless of what is actually best for us. I call the reactive forms of compliance and defiance two sides of the same coin. They're two sides of the same coin because they often go hand in hand and both preclude being autonomous. The defining feature that make them defensive is that they push away our true emotions and they compel us to give people what we think they want or deny people what we think they want. And our behavior is not guided by what is in our best interest. Likely for these reasons, Davanloo refers to compliance and defiance as rooted in the perpetrator of the unconscious, the need to punish the self based on unconscious guilt over unconscious sadism. You can have two people engaging in the same action, but one is reactively engaged in defensive compliance or defiance, and the other is not reacting but responding, in touch with her emotions and doing what is in her best interests. It's the underlying motivation and function of the behavior, not the behavior itself, that determines whether or not defensive compliance and defiance is taking place. The two biggest costs in defensive compliance and defiance have already been alluded to. Loss of autonomy, including difficulties knowing what one wants, and isolation. The person who is reactively and defensively compelled to either give or deny others what they want gives up her autonomy. Her life is not in her own hands, and she is also alone with her true feelings, thoughts, and priorities. On top of these major downsides are whatever other symptoms go along with the repression of their true feelings, which can vary from individual to individual. How do we best help those seeking our help through psychotherapy who engage in compliant and defiant behavior? Important considerations. In the clinical consultation room, patients that are compliant or defiant due to unconscious projective processes will typically have an absence of strided signaling and present as more flat instead. But if the compliance and defiance are more tactical in nature, you may still see some stride and muscular activation. How we help the patient and how to best intervene with these defenses depend on a number of things. Are the defenses conscious or unconscious? Other critical considerations include whether or not the compliance and defiance are largely part of a projective process, major defense, or tactical in nature, and to what extent we have a collaborator or not. To the extent that a conscious and unconscious therapeutic alliance is in operation, to that extent we have a collaborator. If compliance and defiance are more tactical in nature, they may not have characterological roots, but with heavy projective processes, and when compliance and defiance make up major columns of defense and major systems of resistance, then they will invariably have a characterological nature. Also, we look closely at the patient's ego-adaptive capacity, moment-to-moment signaling system, the absence or presence of fragility of the ego, enactments, how egosyntonic versus ego-dystonic the compliance and defiance is to the patient. Keep in mind that people with compliance and defiance, especially those with more fragility who project their will and their superego, not necessarily those who use these defenses tactically, have histories of people trying to change them. And so, in order to not duplicate past traumas, it is very important that whatever intervention we use does not make us one more person in their life that is trying to change them. Trying to change our patients is generally not good practice, regardless of clinical presentation. When the patient is compliant or defiant, and they have not declared their own genuine will towards a therapeutic task, it is critical that when we point out their defenses, that we add something to the effect of, and I'm not telling you not to do this, or that I need you to be different from how you are. These patients will, however, often unconsciously pull for the therapist to fill the vacuum of their passive compliance so that they can go along superficially, but in actuality defy the therapist to perpetuate emotional distancing and self-sabotage. We undo these projections and projective identification processes by not compensating for the patient's passivity by becoming active and not giving the patient anything to defy or comply with. When projections and resistance against emotional closeness is particularly severe, the patient will see you as a demanding figure, regardless of how you act. But by going out of our way to not be that way, it will be harder for the patient to make you out to be what you're not, and easier to help the patient see through their projections. Compliance and defiance dynamics amount to a transferential minefield. They're loaded with risk for creating a transference neuroses and misalliances. Davanloo describes the transference neuroses as a situation in which the patient has transferred all of his character resistance and underlying complex neurotic feelings onto the therapist while maintaining all these neurotic forces locked up within his unconscious. The therapist has become a figure of the patient's past, which gratifies his need, his destructive need. Why should the patient give it up? Personal Communication 2012. With compliance combined with fragility and heavy projections, it's critical that we do not re-traumatize patients by pushing our own agenda onto the patient. We need to convey to the patient that though progress is contingent on them letting go of the compliance and defiance, the relationship with you is not. And that though you have hopes that they will one day have their life in their own hands, you do not need them to change. And that it is not the patient's job to try to take care of your feelings. Where the compliance is deeply ingrained, it can be necessary to take a very hands-off approach in terms of trying to help the patient see and turn against this defense. Since for this type of patient, all communications from the therapist will be filtered through the "here is one more expectation" lens. The therapist's interventions will be experienced as yet more expectations and demands that they need to try to comply with, creating a circular situation where the patient tries to comply with a perceived demand that they should not be compliant. The patient has a right to get as little or as much out of their own therapy as they wish. This needs to be conveyed. And I dare say that with the typical emphasis in ISTDP on pressure, this very easily lends itself to this problem with very compliant patients. The only appropriate form of pressure with patients like this is the pressure that comes from not giving the patient anything to comply with or defy. A narrow understanding of ISTDP can get in the way of just being empathetic when that is what is needed. Sometimes the best intervention with compliant patients is just to say, "Wow, that sounds terrible." These type of patients are often not used to being seen as they are, without anyone trying to change them. They were often never good enough in their parents' eyes. We must take great care not to replicate this trauma. I do believe it's important that the therapist be honest with the patient about having hopes. Keeping this from the patient can generate mistrust, nurture projections, and repeat old damaging relational dynamics where important others were not transparent with them about their expectations. It is often a corrective emotional experience to experience a therapist who can be honest about having hopes, but make it clear that they're not pushing an agenda and that they can accept whatever the patient does or does not do. "Actually, I do have hopes for you. I really do want you to get better. But those are mine, and if you decide to do something else, I'll be sad or maybe frustrated, but I can live with that. It's not your job to take care of me. We're here for your hopes and what you envision for yourself, not what I want. So what is it that you want?" We have to acknowledge that it's not clear what your will is right now. I have my hopes. I have to be honest with you. I'm not neutral. But we're not here to fulfill my hopes. At this point, It's not clear what you want for yourself. Maybe we will get that clarity. Maybe we won't. A compliant patient with heavy projection and will, as well as superego, may call for this intervention. Take all the time you need. I'm here if you decide you want to talk, and I'm here if you decide you don't want to talk. When the patient projects their superego and resistance onto the therapist, it can be helpful to say, "So this is one of those moments when you see me as a negative force in your life. That's how you see me at this moment in time." However we mitigate the patient's projections of their will and superego, where they see us as demanding figures, is the way to go with compliance. The demanding figure combines both projection of will and superego, by the way. Here's an example of work with a patient who's compliant, but the compliance is ego dystonic, projections are not heavy, and there are signs she responds well, becomes less compliant and more genuine and collaborative. Collaborative and compliant are worlds apart in response to greater doses of pressure. Patient: "You seem to be pressuring me to change." Therapist: "I would like you to. Why would I want to see you spend another minute with the agony that brings you here? But if you try to change to please me, this won't work. I can handle being disappointed. You don't need to take care of me. Do you see how you've made me and what I want the main focus of our relationship?" Patient: "I do this with everyone." Therapist: "So this is what you do in all of your relationships. You put yourself on the back burner, and it becomes about what others want. And then we don't know what you want. As long as we don't know what you want, why would our relationship go any different than the other relationships of your life where you remain alone in agony and don't get your needs met?" Patient: "Right. But it's like still, I keep wondering what you want." Therapist: "And then we don't know what you want. Is that okay with you, to make this about fulfilling my hopes rather than your own?" Patient: "No." Therapist: "So let's not get to what I want. What is it that you want?" Patient: "I'm not sure. I know I self-sabotage a lot." Therapist: "Do you want to sabotage our work and perpetuate your agony by making me useless to you, which we can be honest, that is what I am when you're behind this wall, or to lower this wall of compliance and find your freedom from the self-sabotage and suffering that you've been telling me about?" At this point, if her conscious will firms up and becomes unequivocal, then we have a green light to begin to apply heavier doses of pressure on the patient to let go of her defenses and face her complex transference feelings instead. It's important to understand that the primary priority with patients with some fragility who project their will and or their superego or autonomy, agency, is to facilitate a corrective emotional experience. This means that the patient faces the old familiar conflicts of relating to others, now relating to the therapist, but this time with the therapist, there is a new and positive outcome. This corrective emotional experience usually needs to involve an experience of emotional closeness with the therapist, where the patient maintains a sense of being autonomous. I often say to patients with this type of presentation, "Is it true that you have come to associate maintaining relationships and being close to others with loss of autonomy, that you need to be an extension of the other in order to have the relationship?" These types of patients often do feel this way and tend to readily see the merits of the observation. Therapist: "So if your options are just two, to maintain a relationship and some semblance of being close, but giving up your autonomy, or option two, to keep your distance, I can understand why you would go with option two, in spite of the loneliness that comes with that. Because what could be worse than giving up your autonomy?" Here, the patient often feels understood. Therapist: "But what if there's a third alternative? What if you can have a sense of being close to those you want to be close to, but without giving up an iota of your autonomy. Patient, well, that would be nice. At this point, it becomes the therapist's job to help the patient, mainly just cognitively, to acknowledge that they are aware of mixed feelings in the room, with and towards the therapist, as it feels risky to be open and honest, while there's also the sense that the therapist is trying to be helpful and understanding. As soon as the patient can acknowledge, even just cognitively, the mixed emotions, the therapist can inform the patient that they were being emotionally intimate, and did that feel like a loss of autonomy? It rarely does. And so at this point, there's an experiential reference point where the patient has experienced a third alternative where they can have emotional intimacy but remain completely autonomous. So here we ask, how was that for you? Did you realize that you allowed me close? And did it feel like I became the boss of you just there? Or did you feel in charge? This intervention cements the corrective experience where closeness and autonomy go hand in hand, and the old association of closeness and loss of autonomy is undermined. If we press for the patient's feelings or otherwise try to examine the patient's inner life too much before this positive experiential reference point is facilitated, the patient will resist, and the resistance will be healthy, and we will have a misalliance. Not until there is a solid foundation of the patient having an experiential reference point, how they can have closeness and autonomy together, will pressure and invitations to let go of resistance against emotional closeness be therapeutic. Let's turn our attention to ways of working with defiance. With defiance, the organizing principle, and this cannot be stated enough, needs to be to not give the patient anything to defy, to avoid a battle of wills. And when it becomes conscious and comes to a head, assuming that the unconscious defiance was not undone indirectly, but instead makes up the major resistance, to help the patient see that though the stalled therapy is not wonderful for us as therapists, it's not our life that is sabotaged, and it hurts the patient more than it hurts anyone else. I can live with it if you can, is a stance that often helps, and where the defiance is more tactical, not part of a heavy projective process, and beginning to give way to the unconscious therapeutic alliance, greater pressure and challenge often does the job. Why do you want to cripple yourself with this defiant position? Dr. Davanloo makes it clear that defiance is an indirect expression of hostility. Quote, hitherto, the patient has been expressing hostility by defiance and detachment, which are ways of expressing anger without the true experience of anger. From Unlocking the Unconscious, page 18. This gesture expresses a complex set of feelings and impulses. First, there's the obvious defiance in it, but the defiance serves not only to express his hostility towards the therapist, but to put distance between the two of them, thus reducing the anxiety produced by the systematic challenge to his defenses and the threat of emotional closeness. Page 30. Let's revisit Peter von Korff. You are the one to decide if this is a problem or it is not a problem for you. You should not just agree with me, but examine it for yourself. If you want to keep on in this way, then you can. It is your life. Still on Korff. Undermine the opportunity for the patient to engage in a power struggle with the therapist. For example, they may be used in addressing obsessive patients who offer their thoughts in response to questions about their emotions, and then want to engage the therapist in a semantic debate about what is and what isn't a feeling. Deactivation of the defiance communicates to the patient's unconscious that the therapist is simply not offering to be engaged in that way. This message is framed by language which is joining and respectful. Now let's get to a transcript of work with a defiant patient who gets even with people by being defiant and reported anger at therapist for feeling pleasure when the patient is making progress. Therapist: I know it's a lot to give up. It's the best way you have devised to deal with your anger and get back at people you're angry with. And you may want to suffer the consequences, so you can think about it. Patient: True. Therapist: Is this really how you want to spend your life? Being miserable so that other people are also upset. Giving up being miserable is asking you to give up a lot. I understand that. This may be something you decide to hang on to. I hope not. I'm not neutral. But it is asking a lot of you to give this up. It's been a foundation of your life. Maybe you want to think about it. Maybe you want to hang on to it. Patient: I feel in control by defying you. Therapist: I know I'm asking you to give up a lot. This probably got you through your childhood, and now I'm asking you to give it up because it's crippling your life as a way to get back at people by making yourself miserable. Patient: It really feels like a tough choice. Therapist: It's been the one thing you could count on your whole life. The one thing that gave you some sense of being in charge and having some control over your life, even though it's ephemeral and excruciating, and you may not want to give it up. I would understand. I would be sad because I see all of this potential that's being crippled, but I would certainly understand. Here the patient is visibly struggling and taking deep sighs. Therapist: How would it be for you to have this relationship be a failure? How would it be for you? The therapist now gives the patient space. Silence, long silence. The patient continues to take deep sighs. Therapist: Maybe you want to continue to suffer and hurt yourself by remaining defiant and defeating me. That's certainly your right. But what is your will right now? To push away your feelings by remaining crippled like this, as you seem to get some satisfaction from making sure I cannot feel good about myself as your therapist? Or do you want to free yourself from this emotional straitjacket of defiance? Face your rage towards me for getting satisfaction with your progress and see where that takes you. The consequences of your decision are yours, either way. As you can see, the topic of compliance and defiance is a major one that deserves all the attention it can get. Few defenses prove more difficult to deal with and give rise to misalliances when not handled skillfully. Thank you for watching. Until next time.